nursing curriculum, but a fundamental part of patient care. Eye disorders. Think about it. The gift of sight is something we often take for granted, but for millions, it's a fragile gift. From a purely academic perspective, questions on eye disorders are a recurring, high-yield area in your exams. Whether it's NORCET, ESSEC, or your university finals, mastering this topic can significantly boost your score. You'll see questions on glaucoma, cataracts, and nursing interventions for post-op eye patients time and time again. But let's look beyond the exam hall. In the clinical setting, your knowledge here becomes profoundly important. As a nurse, you are often the first line of defense. You're the one who might notice the subtle signs of rising intraocular pressure or the early clouding of a lens. Your prompt assessment and intervention can be the single factor that prevents irreversible vision loss. The difference between sight and blindness can literally rest in your hands, in your ability to observe, report, and act. This isn't just about passing a test. It's about preserving a person's quality of life, their independence, and their ability to see the world. This is why this session is so critical. We're going to break down these complex conditions into understandable, memorable concepts that you can apply directly to your studies and your practice. We'll cover everything from simple refractive errors to the complexities of retinal detachment and glaucoma management. I want you to walk away from this feeling confident and prepared. So please, listen carefully. यह टॉपिक एग्जाम प्लस वार्ड दोनों में काम आएगा. Let's begin this journey to not just score marks, but to save sight. Let's start with the most common eye issue many of us are familiar with. Refractive errors. Simply put, a refractive error means the shape of your eye doesn't bend light correctly, resulting in a blurred image. Light needs to be focused perfectly onto the retina, the light-sensitive tissue at the back of the eye, for clear vision. When that doesn't happen, we get conditions like myopia or nearsightedness, where distant objects are blurry, hypermetropia or farsightedness, where near objects are blurry, and astigmatism, which causes blurry vision at all distances due to an imperfectly shaped cornea. Finally, there's presbyopia, the age-related farsightedness that makes reading up close difficult for many over 40. The key to management is accurate diagnosis, usually with a Snellen chart to test visual acuity, and a retinoscope to measure the refractive error. Management is straightforward. Corrective lenses, either eyeglasses or contact lenses, are the primary solution. For some, refractive surgeries like LASIK offer a more permanent correction. As nurses, your role is crucial in education. You'll explain the importance of regular eye exams, especially for children and those with a family history. You'll teach patients proper contact lens hygiene to prevent infections and advise on ergonomic adjustments, like screen distance and lighting, to reduce eye strain. It's about empowering patients with knowledge for long-term eye health. Now let's shift our focus to the protective gates of the eyelids. One of the most common acute issues you'll see is a stye, or hordeolum. This is a small, painful, pus-filled lump on the edge of the eyelid, essentially a bacterial infection of an oil gland. Patients will complain of pain, redness, and swelling. Management is often conservative. The cornerstone of nursing care is applying warm compresses for about 10 to 15 minutes, several times a day. This helps the stye to drain on its own. It's vital to educate patients not to squeeze or pop the stye, as this can spread the infection. In some cases, a doctor might prescribe an antibiotic ointment. Beyond infections, we have structural eyelid deformities. Ptosis is the drooping of the upper eyelid, which can be congenital or acquired and may obstruct vision. Entropion is where the eyelid, usually the lower one, turns inward, causing the eyelashes to rub against the cornea, leading to irritation and potential scarring. Its opposite is ectropion, where the eyelid turns outward, leading to dry eyes and excessive tearing. For these conditions, management is primarily surgical. As a nurse, your role involves pre-operative and post-operative care, including administering eye drops, applying ointments, and educating the patient on wound care and signs of infection to ensure a smooth recovery. A red eye is one of the most frequent complaints that brings a patient to a clinic, and the usual suspect is conjunctivitis, or pink eye. This is the inflammation of the conjunctiva, the thin membrane covering the white of the eye and the inside of the eyelids. It can be viral, which is highly contagious and often associated with a cold; bacterial, which produces a thick yellow-green discharge; or allergic, characterized by intense itching and watery eyes. Management depends on the cause. Viral conjunctivitis is self-limiting, while bacterial forms require antibiotic eye drops. Allergic types are managed with antihistamine drops and avoiding allergens. Your nursing care here is centered on infection control and patient education. For infectious conjunctivitis, stress the importance of frequent hand washing, not sharing towels or pillows, and avoiding touching the eyes. For all types, cool compresses can soothe discomfort. Another condition you might encounter is a subconjunctival hemorrhage. This looks alarming, a bright red patch on the white of the eye, but it's usually harmless, like a bruise on the skin. It occurs when a tiny blood vessel breaks. The primary nursing intervention here is reassurance. Explain to the patient that it's painless, doesn't affect vision, and will resolve on its own in a week or two, just like a bruise fades. Moving deeper into the eye's anatomy, we come to the cornea, the transparent front part of the eye that covers the iris and pupil. Inflammation of the cornea is called keratitis, and it's a serious condition that can threaten sight. The causes are varied. It can be infectious, from bacteria, viruses like herpes simplex, fungi, or even parasites, often linked to improper contact lens wear. It can also be non-infectious, caused by an injury, a foreign body, or severe dry eye. Symptoms are a red flag: intense pain, severe light sensitivity, which we call photophobia, blurred vision, and a feeling that something is in the eye. Diagnosis involves a slit lamp examination, and sometimes a corneal scraping is taken to identify the infectious agent. Management must be aggressive and targeted. Bacterial keratitis requires intensive antibiotic drops, sometimes every hour, while fungal and viral forms need specific antifungal or antiviral medications. As a nurse, your role is critical. You will be responsible for the strict administration of the eye drop regimen, which is paramount for success. You must also educate the patient on the importance of compliance, avoiding eye rubbing, and proper hygiene. For patients with severe photophobia, keeping the room dimly lit can provide significant comfort. This is an ophthalmic emergency. Your diligence can save a patient's cornea. Imagine looking at the world through a foggy or frosty window. That's what it's like for someone with a cataract. A cataract is a clouding of the eye's natural lens, which lies behind the iris and the pupil. The lens works much like a camera lens, focusing light onto the retina to produce a clear, sharp image. As we age, proteins in the lens can start to clump together, creating a cloudy area. This is the most common type, an age-related cataract. Other risk factors include diabetes, smoking, prolonged sun exposure, and eye injuries. The primary symptom is a painless, progressive blurring of vision. Patients might also report faded colors, glare or halos around lights, and difficulty seeing at night. Diagnosis is confirmed through a comprehensive eye exam. Initially, stronger glasses and brighter lighting might help, but the only effective treatment for a cataract is surgery. This involves removing the cloudy natural lens and replacing it with a clear artificial one called an intraocular lens, or IOL. Your nursing care plan is extensive, covering pre-op and post-op phases. Pre-operatively, you'll administer dilating eye drops and provide patient education. Post-operatively, you'll teach the patient how to administer their prescribed antibiotic and anti-inflammatory drops, advise them to wear an eye shield, especially at night, and instruct them on activity restrictions, like avoiding bending over or heavy lifting, to prevent increased intraocular pressure. We now turn to one of the most insidious eye diseases, glaucoma. I call it the silent thief of sight because it often has no early symptoms and can gradually steal your vision without you even knowing it. Glaucoma is a group of eye conditions that damage the optic nerve, which is vital for vision, connecting the eye to the brain. This damage is often caused by abnormally high pressure inside your eye, known as intraocular pressure or IOP. There are two main types. Open-angle glaucoma is the most common, progressing slowly and painlessly, causing a gradual loss of peripheral vision. Angle closure glaucoma is less common, but can be acute and is a medical emergency, presenting with severe eye pain, nausea, and blurred vision. Diagnosis involves measuring IOP, or tonometry, checking for optic nerve damage, and testing visual fields. The goal of management is to lower the IOP to prevent further optic nerve damage. This is first attempted with medicated eye drops. If drops are not effective enough, laser therapy or surgery, like a trabeculectomy, might be necessary to improve fluid drainage from the eye. Nursing care is heavily focused on patient education and adherence. You must teach patients that glaucoma is a lifelong condition. They need to understand the importance of using their eye drops exactly as prescribed every single day to control the pressure. You'll also teach them the punctal occlusion technique, pressing on the corner of the eye after instilling drops, to maximize absorption and minimize systemic side effects. Retinal detachment is a true ophthalmic emergency. It describes a situation where the retina, the thin layer of tissue at the back of the eye, pulls away from its normal position. When the retina is detached, it is separated from its blood supply and can no longer function, leading to vision loss. Imagine a curtain falling over your field of vision. That's a classic description from a patient. Other key symptoms include a sudden increase in floaters, which are tiny specks that drift through your field of vision, sudden flashes of light in one or both eyes, and a shadow or blurriness in your peripheral vision that spreads. Immediate medical attention is crucial to save the vision in the affected eye. Diagnosis is made by an ophthalmologist using an ophthalmoscope to view the retina. Management is almost always surgical. Procedures like pneumatic retinopexy, vitrectomy, or a scleral buckle are used to reattach the retina. Your nursing care, especially post-operatively, is vital. Depending on the procedure, the patient may need to maintain a specific head position, for instance face down, for several days to allow a gas bubble to press the retina back into place. This is challenging for the patient, and your role is to provide comfort, support, and clear instructions to ensure compliance and promote successful healing. Navigating the world without sight. Blindness. Blindness is the end stage of many of the diseases we've discussed. It's defined as a corrected visual acuity of 20/200 or less in the better eye, or a visual field of 20 degrees or less. The causes are numerous, with cataract, glaucoma, age-related macular degeneration, and diabetic retinopathy being the leading culprits globally. When a patient faces vision loss, whether partial or complete, it's a life-altering event that impacts every aspect of their existence, from mobility and daily activities to their sense of identity and independence. The psychological impact, fear, depression, and anxiety can be profound. As a nurse, your management shifts from curative to supportive and rehabilitative. Your role becomes one of a guide, an advocate, and a source of profound empathy. You will connect patients and their families with resources like low vision specialists, orientation and mobility training, and support groups. You'll help them adapt their home environment for safety, ensuring clear pathways, good lighting, and using high contrast markings. It's about teaching new skills, like using a white cane or learning Braille, and introducing assistive technologies that can read text aloud. Your non-judgmental support and encouragement are essential in helping the patient navigate their new reality and regain a sense of control and purpose. the gift of sight, eye donation, and transplantation. In our final chapter, we discuss a topic of incredible hope: eye donation and transplantation. For many who are blind due to corneal disease, a corneal transplant, or keratoplasty, is the only way to restore sight. This is only possible through the selfless act of eye donation. Eye donation is the process of donating one's eyes after death. It's important to clarify that the whole eye is not transplanted. Rather, the cornea, the clear outer layer, is used. Anyone can be a potential donor, regardless of age, blood type, or even if they had poor eyesight or wore glasses. The process is managed by an eye bank, which is a non-profit organization responsible for the collection, evaluation, storage, and distribution of donated corneas. The nurse's role in this process is multifaceted and deeply impactful. In the hospital setting, you may be the one to approach a grieving family about the possibility of donation. This requires immense sensitivity, compassion, and clear communication. You are also a key educator in the community, dispelling myths and raising awareness about the critical need for donors. By encouraging individuals to pledge their eyes, you are helping to build a culture of donation and giving countless people a second chance at sight. It is a powerful legacy. Your vision for the future of care. We've covered a vast and vital landscape today, from the simplest refractive errors to the profound act of eye donation. The common thread weaving through every single one of these topics is the irreplaceable role of the nurse. Whether you are in a bustling outpatient clinic, a high-stakes operating room, or a quiet community health center, your skills, your vigilance, and your compassion are central to preserving and restoring vision. It's about knowing when a red eye is a simple allergy versus when it's a sight-threatening keratitis. It's about ensuring a post-op cataract patient understands their drop schedule and activity limits. Students, eye disorders demand early detection, correct nursing care, and patient education. Remember, a nurse can prevent blindness by timely action. The knowledge you've gained today is not just for your exams. It's a toolkit you will carry with you throughout your entire career. Every time you correctly identify a symptom, patiently teach a patient a new skill, or provide comfort to someone facing vision loss, you are making a tangible difference. You are the frontline guardians of sight. Thank you for investing your time with me today. Continue to study with passion and purpose. Remember the faces and stories behind the conditions we've discussed. Go forward with the confidence that you have the power to protect one of humanity's most precious gifts. If you found this helpful, please like, subscribe, and share it with your colleagues. Together, let's build a community of nurses dedicated to excellence in eye care. Until next time, take care. Hello, future lifesavers. Today, we're diving into the amazing world of eye care. Think about our eyes for a moment. They are like tiny, super-powered cameras that let us see everything from a beautiful sunset to the faces of the people we love. They are incredibly precious, but also very delicate. As nurses, you are in a unique and powerful position to protect this precious gift of sight. Your sharp eyes and caring hands can make a huge difference in someone's life, helping to keep their world bright and clear. You are the first line of defense in the battle against preventable blindness, and that is a very important job indeed. Your role goes far beyond just giving out eye drops. You will be the person who listens carefully to a patient's worries about their vision. You will be the one to spot the early warning signs of a serious eye problem that others might miss. By understanding how the eye works and what can go wrong, you can act quickly. This early detection is absolutely key. Many conditions that can lead to blindness, like glaucoma, can be managed effectively if they are caught in their initial stages. Your knowledge and vigilance can literally save someone's sight, preventing darkness from clouding their future. Preventing blindness is a global health priority, and nurses are at the very heart of this mission. You'll teach patients how to protect their eyes, from wearing sunglasses to managing health conditions like diabetes that can affect vision. You will comfort them when they are scared about a diagnosis or an upcoming surgery. You will guide them through their treatment, ensuring they use their medications correctly and safely. Your compassion and expertise provide a beacon of hope and support, empowering patients to take an active role in their own eye health and well-being. So, as we begin this journey, remember the immense trust your patients will place in you. They are trusting you with their vision, one of their most vital senses. This guide is designed to give you the foundational knowledge you need to be confident and competent in caring for patients with eye and ENT conditions. Embrace this responsibility with enthusiasm and dedication. By mastering these essential skills, you won't just be a nurse. You'll be a true guardian of sight, making a profound and lasting impact on every patient you care for. To understand what goes wrong with the eye, we first need to know how it's built. Think of the eye like a little globe with 3 special layers. The outermost layer is the tough, protective one. It includes the white part, called the sclera, which gives the eye its shape. At the very front, this layer becomes the transparent cornea, which is like a clear window that lets light in. It's the first and most powerful part of the eye's focusing system. This tough outer shell is vital for protecting all the delicate structures that are housed safely inside it. The middle layer is called the uvea, and it's all about blood supply and focus. This layer contains the choroid, which is packed with blood vessels that nourish the back of the eye. Towards the front, we find the ciliary body, a clever muscle that changes the shape of the lens to help us focus on things up close or far away. It also produces a fluid called aqueous humor that keeps the front of the eye healthy. The colorful part of your eye, the iris, is also here. The iris controls the size of the pupil, which is the black hole in the middle, to regulate how much light enters the eye. The innermost layer is the retina, and this is where the real magic happens. The retina is like the film in a camera, or the sensor in a digital camera. It's a light-sensitive tissue that lines the back of the eye. It contains millions of special cells called photoreceptors, rods for seeing in dim light, and cones for seeing color and fine detail. When light hits the retina, these cells convert it into electrical signals. At the center of the retina is the macula, which is responsible for our sharp, detailed central vision that we use for reading and driving. So how does this all come together to create vision? It's a brilliant step-by-step process. First, light rays bounce off an object and travel towards your eye. They pass through the clear cornea, which starts to bend the light. The light then goes through the pupil. Next, it hits the lens, which fine-tunes the focus by changing its shape, a process called accommodation. The focused light then travels through the jelly-like vitreous humor that fills the eye, finally landing on the retina at the back. The photoreceptor cells in the retina turn this light into electrical signals, which are then sent to the brain via the optic nerve. The brain then interprets these signals, and voila, you see the object. When a patient comes to you with an eye complaint, you become a detective. Your first and most important tool is asking the right questions. A thorough patient history is the foundation for a correct diagnosis. Start with the main problem. What brought them in today? Ask them to describe the issue in their own words. Is it pain, redness, discharge, blurry vision, double vision, or something else? Then, dig deeper. When did it start? Did it come on suddenly or gradually? Is it in one eye or both? Does anything make it better or worse? These initial questions help you frame the entire clinical picture. Next, you need to explore the characteristics of the symptom. If there is pain, ask them to rate it on a scale of 1 to 10 and describe its quality. Is it sharp, dull, aching, or a feeling of pressure? If there's discharge, what color is it, and is it watery or thick? If their vision is blurry, is it constant, or does it come and go? Ask about other associated symptoms like seeing floaters, little specks, flashes of light, halos around lights, or increased sensitivity to light. known as photophobia. Also, inquire if they have a sensation of something being in their eye, often called a foreign body sensation. A person's medical history provides vital clues. Ask about any past eye problems, injuries, or surgeries. Do they wear glasses or contact lenses? It's also crucial to ask about their general health. Conditions like diabetes, high blood pressure, and autoimmune diseases can have a significant impact on eye health. Find out what medications they are taking, including over-the-counter drugs and eye drops, as some can have side effects that affect the eyes. Don't forget to ask about family history. Are there any eye conditions, like glaucoma or macular degeneration, that run in their family? After gathering the history, you move on to the physical assessment. Start by just looking at the eyes. Check for symmetry, swelling, redness, or any obvious abnormalities of the eyelids and surrounding structures. Look at the sclera for yellowness, jaundice, or redness. Check the cornea for clarity and the conjunctiva for inflammation. A simple pen light is your best friend here. Then, test visual acuity using a Snellen chart. Have the patient stand 20 feet away and read the smallest line they can see, testing each eye separately. Finally, assess the pupils. Check their size, shape, and equality. Use your pen light to check their reaction to light and accommodation, a test often remembered by the acronym PERLA. Pupils equal, round, and reactive to light and accommodation. While a good history and physical exam can tell you a lot, sometimes you need to look deeper to find the answers. Doctors rely on a range of diagnostic tests to get a clearer picture of what's happening inside the eye. As a nurse, you'll often be involved in preparing patients for these tests, explaining what will happen, and providing care afterwards. Understanding these tests will help you answer your patients' questions and reduce their anxiety. These investigations provide objective data that confirms a suspected diagnosis and helps guide the most effective treatment plan for the patient. One of the most common tests is tonometry. This test measures the pressure inside the eye, which is known as intraocular pressure, or IOP. It is a critical test for diagnosing and monitoring glaucoma, a condition where high pressure can damage the optic nerve. There are several ways to perform tonometry. The air puff test, or non-contact tonometry, is quick and painless. A more accurate method is applanation tonometry, where the doctor uses a special instrument that gently touches the surface of the anesthetized cornea to measure the pressure. Your role is to reassure the patient that the test is not painful. Another key investigation is the slit lamp examination. This is not just a test, but a detailed microscopic examination of the eye. The patient rests their chin and forehead on a support, while the ophthalmologist uses a special microscope with a high-intensity light beam, the slit, to look at the eye in fine detail. This instrument allows the doctor to examine the cornea, iris, lens, and the front part of the vitreous humor. It is essential for diagnosing a huge range of conditions, from cataracts and corneal ulcers to inflammation inside the eye, known as uveitis. For looking at the back of the eye, a fundoscopy or ophthalmoscopy is performed. This allows the doctor to see the retina, the optic disc, where the optic nerve enters the eye, and the network of blood vessels. This can be done with a handheld ophthalmoscope, which you will learn to use, or through the slit lamp with a special lens. To get a better view, the pupil may be dilated with eye drops. This examination is vital for detecting diabetic retinopathy, macular degeneration, and signs of optic nerve damage from glaucoma. More advanced tests, like fluorescein angiography, where a dye is injected into the arm to highlight retinal blood vessels, can provide even more detail. Now let's talk about some of the most common eye disorders you will encounter. First up is conjunctivitis, often called pink eye. This is an inflammation of the conjunctiva, the thin, clear membrane that covers the white of the eye and lines the eyelids. It can be caused by viruses, bacteria, or allergens. viral and bacterial conjunctivitis are highly contagious. Signs include redness, itchiness, a gritty feeling, and discharge, watery for viral, and thick and yellow or green for bacterial. Allergic conjunctivitis often comes with intense itching and watery eyes. Management involves good hygiene, hand washing to prevent spread, and treatment with antibiotic eye drops for bacterial cases or antihistamine drops for allergies. Next is cataracts, a very common condition, especially in older adults. A cataract is a clouding of the eye's natural lens, which lies behind the iris and pupil. It's like trying to look through a foggy or dusty window. The main risk factor is age, but others include diabetes, smoking, and prolonged sun exposure. Patients will complain of progressively blurry or dim vision, faded colors, and increased glare from lights, especially at night. The only effective treatment is surgery, where the cloudy lens is removed and replaced with a clear, artificial one. Nursing care focuses on pre- and post-operative education and care. Glaucoma is a more serious condition, often called the silent thief of sight, because it can cause irreversible vision loss with no early symptoms. It's a group of diseases that damage the optic nerve, usually due to high intraocular pressure, or IOP. The most common type, open-angle glaucoma, develops slowly and painlessly, causing a gradual loss of peripheral or side vision. Risk factors include age, family history, and being of African or Hispanic descent. Management involves lifelong treatment with eye drops to lower eye pressure. Nursing management is huge here, focusing on educating patients about the importance of sticking to their medication schedule to prevent further vision loss. Finally, we have refractive errors, which are the most common reason people need glasses or contact lenses. These aren't diseases but problems with how the eye focuses light. Myopia, or nearsightedness, means you can see close objects clearly, but distant objects are blurry. Hyperopia, or farsightedness, is the opposite. Astigmatism is an imperfection in the cornea's curvature, causing blurred vision at all distances. Presbyopia is the age-related difficulty with near vision, which is why many people need reading glasses after age 40. The management is simple: correction with eyeglasses, contact lenses, or refractive surgery like LASIK. Providing excellent nursing care for patients with eye conditions involves a blend of technical skill, clear communication, and compassionate support. A fundamental aspect of this care is proper eye hygiene. You must teach patients, especially those with infections like conjunctivitis, the importance of frequent and thorough hand washing. They should avoid touching or rubbing their eyes, as this can spread infection or cause further irritation. Instruct them to use a clean tissue to gently wipe away any discharge, always wiping from the inner corner of the eye outwards to prevent contaminating the tear duct. Administering eye medication correctly is a critical nursing skill. Whether you are giving drops or ointment, the technique matters for safety and effectiveness. First, always wash your hands and check the medication label carefully. Right patient, right drug, right eye. Ask the patient to tilt their head back and look up. Gently pull down the lower eyelid to create a small pocket. For drops, hold the bottle above the eye and squeeze one drop into the pocket, not directly onto the cornea. For ointment, apply a thin ribbon along the inside of the lower eyelid. In both cases, tell the patient to close their eye gently and press on the inner corner to prevent the medication from draining away. Patient education is perhaps your most powerful tool. Patients are often anxious about their vision and may be overwhelmed by new routines. You need to explain their condition and treatment plan in simple, clear language. For a patient with glaucoma, you must stress that while there is no cure, consistent use of their eye drops can save their sight. For a patient recovering from cataract surgery, you'll provide clear instructions on activity restrictions, wearing an eye shield, and recognizing signs of complications like increased pain or vision loss. Using teach-back methods ensures they truly understand. Beyond the physical care, providing emotional support is just as important. A new diagnosis that threatens vision can be terrifying. Listen to your patient's fears and concerns with empathy. Reassure them and connect them with resources, such as support groups or low-vision specialists if needed. For patients undergoing surgery, a calm and confident demeanor from you can significantly reduce their anxiety. Your role is holistic. You are not just treating an eye, you are caring for a whole person who is navigating a challenging experience. Your kindness can make all the difference in their journey. To wrap things up, let's reflect on the incredible role you are preparing to play. As a nurse, you are so much more than just a caregiver. You are a guardian of sight. The knowledge you've gained about the eye's anatomy, common disorders, and essential nursing interventions forms the bedrock of safe and effective care. Having a strong grasp of these basics allows you to assess patients confidently, identify red flags quickly, and intervene appropriately. This foundation is not just about passing exams. It is about building the competence to protect one of humanity's most cherished senses in your future patients. Your ability to perform a thorough assessment and take a detailed history can be the deciding factor in early detection. You might be the first healthcare professional to notice the subtle signs of glaucoma during a routine check, or to recognize that a patient's blurry vision is a symptom of uncontrolled diabetes. This early detection is the single most important step in preventing irreversible vision loss. By being vigilant and curious, you initiate a chain of events that can lead to timely treatment and preserve a person's quality of life for years to come. Never underestimate the power of your observation skills. Safe nursing care is paramount, especially when dealing with such a delicate organ. Correctly administering medications, maintaining strict hygiene to prevent infections, and providing clear pre- and post-operative instructions are not just tasks on a checklist. They are critical actions that prevent complications and promote healing. A mistake in medication or a lapse in sterile technique can have devastating consequences for a patient's vision. Your commitment to meticulous evidence-based practice is a direct commitment to the safety and well-being of those you care for. Ultimately, your impact is measured not just in clinical outcomes, but in the hope and empowerment you provide. By educating your patients, you give them the tools to manage their own health. By offering a listening ear and a reassuring presence, you help them navigate fear and uncertainty. The world of eye and ENT nursing is a field where you can see the direct results of your skill and compassion every single day. As you move forward in your career, carry this knowledge with pride, and remember that with every patient you help, you are truly making their world a brighter place. Hello, future nurses. Welcome to a journey into the world of ears, noses, and throats, or what we often call ENT. As you step into your clinical practice, you will quickly discover that problems in these areas are incredibly common. Almost every single patient you meet, from the tiniest baby to the most senior adult, will have experienced an issue like a blocked nose, a sore throat, or a troublesome cough at some point. These conditions are a massive part of everyday healthcare, filling up waiting rooms in GP surgeries and leading to many hospital visits. They might seem simple, but they can have a big impact on a person's quality of life, affecting their ability to breathe, sleep, eat, and communicate with others. Understanding these conditions is therefore absolutely essential for you. It's not just about knowing the big, dramatic diseases. It's about mastering the everyday health problems that affect so many. Think about the common cold, an infection of the upper respiratory tract. It's one of the most frequent reasons people miss work or school. Or consider how a simple ear infection can cause immense pain and distress for a child and their worried parents. As nurses, you will be the first point of contact for many of these patients, and your knowledge will be their first source of comfort and guidance. Your ability to assess their symptoms accurately is the first step toward getting them the right help. This guide is designed to give you a clear and simple overview of these common ENT problems. We will start by looking at the basic building blocks, the anatomy of the upper respiratory system, so you understand how everything is connected.
Then we will dive into specific conditions like nasal and laryngeal obstructions, rhinitis, sinusitis, and deafness. For each one, we will explore what it is, what causes it, how to spot it, and how we, as a healthcare team, manage it. The goal is to build your confidence so you can provide the best possible care for your patients. Remember, your role goes far beyond just giving out medicine. You are an educator, a supporter, and a watchful guardian of your patients' well-being. A key part of your job will be to spot the early warning signs that a simple problem might be turning into something more serious. You will also be the one teaching patients how to manage their conditions at home, explaining treatments, and providing a listening ear when they are feeling anxious or scared. This essay will equip you with the foundational knowledge you need to excel in this vital aspect of nursing care, making a real difference in your patients' lives every single day.
Let's start with a quick tour of the upper respiratory tract. Think of it as the main entrance to your body's amazing breathing system. This system starts at your nose and mouth and includes the pharynx, which is your throat, and the larynx, or your voice box. The nose is much more than just the part you see on your face. It has a complex internal structure with passages called nasal cavities. These cavities are lined with a special mucous membrane and tiny hairs called cilia. This setup isn't just for show. It's a brilliant built-in air conditioning and purification system that prepares air for your delicate lungs. The main job of your nose is to warm, humidify, and filter the air you breathe in. As air rushes through your nasal passages, it gets warmed up to body temperature, so it doesn't deliver a cold shock to your lungs. The mucous membrane adds moisture to the air, preventing the airways from drying out. At the same time, the cilia and the sticky mucus work together like a fantastic trap, catching dust, pollen, bacteria, and other unwanted particles before they can travel further down. This is your body's first and most important line of defense against airborne germs and pollutants, working silently with every breath you take. From the nose, the air moves down into the pharynx, which is the part of your throat behind your mouth and nasal cavity. The pharynx is a clever crossroads, as it serves both the respiratory and digestive systems. It's the shared pathway for the air you breathe and the food you swallow. It then divides into the esophagus, the tube to your stomach, and the larynx. The larynx, or voice box, sits at the top of the trachea, your windpipe. It's made of cartilage and contains your vocal cords, which vibrate to produce sound when you speak, sing, or shout. The larynx has another incredibly important job, protecting your airway. A small leaf-shaped flap of cartilage called the epiglottis acts like a traffic controller. When you breathe, it stays open, letting air flow freely into the trachea. But when you swallow, it cleverly flips down to cover the opening of the larynx. This action directs food and drink away from your lungs and safely down into your esophagus. This simple but vital reflex prevents you from choking. Understanding this basic anatomy is the key to figuring out what goes wrong when patients have breathing or swallowing problems. A nasal obstruction is exactly what it sounds like. A blockage in your nose that makes it difficult to breathe through it. We've all felt this with a common cold, but for some people, it can be a long-term problem. This blockage can happen in one or both nostrils and can be caused by many different things. Think of it like a traffic jam in your nasal passages. The road can be narrowed by swelling of the nasal lining, or it can be physically blocked by something that shouldn't be there. It's a very common complaint that can significantly affect sleep, exercise, and a person's overall sense of well-being. The causes are varied. Swelling is a frequent culprit, often due to allergies, which we call allergic rhinitis, infections like the common cold or sinusitis, or a reaction to irritants like smoke or strong smells. Physical blockages can also occur. A deviated septum, where the wall of cartilage between the two nostrils is bent to one side, is a very common structural cause. Other causes include nasal polyps, which are soft, non-cancerous growths on the lining of the nose, or enlarged adenoids, which are glands at the back of the nose, especially in children. In rare cases, a foreign object, like a bead or a pea in a child's nose, or a tumor, can cause the blockage. Spotting the signs is usually straightforward. The main symptom is, of course, difficulty breathing through the nose. This often leads to mouth breathing, which can cause a dry mouth and throat, especially at night. Patients might also complain of a stuffy or bunged-up feeling, snoring, and disturbed sleep. Sometimes they may have a runny nose, facial pain, or pressure if sinusitis is also present, or a reduced sense of smell. For diagnosis, a doctor will often just need to take a good history and look inside the nose with a special light and instrument called a speculum. Sometimes a small camera on a flexible tube, a nasal endoscopy, is used to get a better view. Management depends entirely on the cause. For swelling from allergies or infections, treatments like nasal steroid sprays, antihistamine tablets, or decongestants can be very effective. If the cause is structural, like a severe deviated septum, or large nasal polyps that don't respond to medication, surgery might be needed. A septoplasty can straighten the septum, while a polypectomy removes the polyps. A simple nursing care plan might look like this. Subjective. Patient says, "I can't breathe through my nose and I snore all night." Objective. Patient is breathing through their mouth. Nasal passages appear swollen. Nursing diagnosis. Ineffective breathing pattern related to nasal congestion. Goal. Patient will report improved nasal breathing within 48 hours of starting nasal spray treatment. Rhinitis and sinusitis are two very common conditions that often go hand in hand. Rhinitis is the inflammation and swelling of the mucous membrane inside your nose. The classic signs are a runny nose, sneezing, itching, and nasal congestion. Think of it as your nose's lining becoming irritated and overreacting. Sinusitis is inflammation of the lining of the sinuses, which are the air-filled cavities in the bones of your face around your nose. When these get inflamed, they can't drain properly, leading to a buildup of mucus, pressure, and pain. Because the lining of the nose and sinuses are connected, it's very common to have both at the same time, a condition we call rhinosinusitis. There are two main types of rhinitis, allergic and non-allergic. Allergic rhinitis, often called hay fever, is triggered by allergens like pollen, dust mites, pet dander, or mold. Your immune system mistakes these harmless substances for a threat and releases chemicals like histamine, which cause all the annoying symptoms. Non-allergic rhinitis causes similar symptoms but isn't triggered by an allergy. It can be set off by things like strong odors, changes in the weather, certain foods, or viral infections. Sinusitis is most often caused by a viral infection, like the common cold. The virus causes the lining to swell, trapping mucus and creating a perfect breeding ground for bacteria, which can sometimes lead to a secondary bacterial infection. The symptoms of rhinitis include a persistent runny nose, with clear mucus in allergies, sneezing, an itchy nose and eyes, and congestion. For sinusitis, the key symptoms are a blocked nose, a thick, discolored nasal discharge, yellow or green, and pain or pressure in the face. This pain might feel worse when you bend forward and can be felt over the cheeks, forehead, or around the eyes. Other signs can include a headache, a reduced sense of smell, fever, and even toothache, as the roots of your upper teeth are close to the maxillary sinuses. Diagnosing these conditions is usually based on the patient's symptoms and a physical examination. Treatment for rhinitis focuses on avoiding triggers and controlling symptoms. For allergic rhinitis, antihistamines and nasal steroid sprays are the mainstays of treatment. Saline nasal rinses can also be very helpful for washing out allergens and mucus. For sinusitis, if it's viral, it will usually get better on its own, with simple pain relief, decongestants, and rest. If it's thought to be bacterial and severe or persistent, a doctor might prescribe antibiotics. For chronic sinusitis that doesn't clear up, surgery may be an option to improve the drainage of the sinuses. As a nurse, you'll spend a lot of time educating patients on how to use their nasal sprays correctly and manage their symptoms at home. Let's put our knowledge into practice by creating a more detailed nursing care plan for a typical patient. Imagine we have Mrs. Gable, a 45-year-old teacher who has come to the clinic. She looks tired and is holding her head. This is our first step, observation. Nursing care starts the moment you see your patient. We need to gather information from her, what we call subjective data, and from our own examination, which is the objective data. This information helps us to identify the main problem, which we state as a nursing diagnosis. From there, we can set a clear, achievable goal for her care and plan the steps to get there. First, we collect the data. Subjective data. Mrs. Gable tells us, "I've had this awful headache for 5 days. It feels like a terrible pressure behind my eyes and in my cheeks, and it's worse if I bend over. My nose is completely blocked, and I've been blowing out this thick yellow stuff. I feel so tired and achy, and I can't smell my morning coffee anymore." Objective data. During our assessment, we note that her temperature is slightly elevated at 37.9 degrees Celsius. When we gently press over her cheeks, or maxillary sinuses, she flinches and says it's very tender. Her nasal passages look red and swollen, and we can see thick yellow discharge. Next, we formulate a nursing diagnosis. Based on our data, a primary diagnosis would be acute pain related to inflammation and pressure in the paranasal sinuses, as evidenced by the patient's report of a pressure headache and facial tenderness on palpation. We could also add a secondary diagnosis, such as fatigue related to systemic infection and sleep disturbance. The nursing diagnosis is crucial because it guides our actions. It's not a medical diagnosis like sinusitis. Instead, it focuses on the human response to the health problem that we, as nurses, can address directly through our care. Now, we set a goal and plan our interventions. Our main goal. Mrs. Gable will report a reduction in pain from an 8 out of 10 to a 4 out of 10 or less within 24 hours, and she will be able to identify 3 non-pharmacological methods for pain relief. Our nursing interventions would include: first, administering pain relief medication as prescribed by the doctor. Second, encouraging her to rest and drink plenty of fluids to help thin the mucus. Third, teaching her to apply warm compresses to her face to ease the pressure. Fourth, showing her how to perform a saline nasal rinse to help clear the congestion. And finally, educating her on when to return if symptoms worsen. For example, if she develops a very high fever or severe headache. Now we move to a much more serious and urgent condition, laryngeal obstruction. This is a blockage of the larynx, or voice box. As we learned, the larynx is the narrowest part of the upper airway in adults, so any swelling or blockage here can be life-threatening. It can cut off the air supply to the lungs, and if it's not treated immediately, it can lead to respiratory arrest and death. This is a true medical emergency, and as a nurse, your ability to recognize the signs quickly and act decisively is absolutely critical. Every second counts when someone's airway is compromised. The causes of laryngeal obstruction can be diverse. In adults, one of the most severe causes is anaphylaxis, a massive allergic reaction where the tissues of the throat swell up rapidly. Inhaling smoke or toxic fumes can cause similar swelling. Infections, such as epiglottitis, meaning inflammation of the epiglottis, although now rarer in children due to vaccination, can still occur in adults and cause a critical blockage. A foreign body, like a piece of food, getting lodged in the larynx is another common cause, often referred to as choking. In a hospital setting, swelling can occur after neck surgery or trauma to the neck. The signs and symptoms of a laryngeal obstruction are dramatic and hard to miss. The person will be in obvious distress, struggling to breathe. You might hear a high-pitched crowing sound as they breathe in, which we call inspiratory stridor. This sound is a red flag that indicates a severe narrowing of the upper airway. The person may become hoarse, or lose their voice completely. They will likely be very anxious, grabbing at their throat, and as their oxygen levels drop, their skin, lips, and nail beds may start to turn blue, a sign called cyanosis. They may use their neck and chest muscles to try and pull air in, which we call using accessory muscles. Management is all about securing the airway immediately. This is the A for airway in any ABC: airway, breathing, circulation, assessment. The priority is to call for help straight away. Shout for the emergency team or call 999. While waiting, try to keep the patient calm and sitting upright, as this can make breathing easier. If choking is suspected, basic life support measures like back blows and abdominal thrusts should be performed. In the hospital, medical treatment may involve giving high-flow oxygen, nebulized adrenaline to reduce swelling, and steroids. If these measures fail, the doctor may need to perform an emergency procedure like intubation, placing a breathing tube, or a cricothyroidotomy, which is making a surgical opening in the neck to bypass the blockage. Shifting our focus from the airway to the ear, let's talk about deafness, or hearing loss. This is a condition where a person's ability to hear is reduced. It can range from being mild, where someone might struggle to hear whispers, to profound, where they can't hear loud sounds at all. Hearing loss is incredibly common, especially as people get older. It can affect one or both ears and can happen gradually over many years or suddenly. It's important to understand that hearing loss isn't just about the volume of sound. It can also affect the clarity, making speech sound muffled or distorted, which can be very frustrating for the individual. There are two main types of hearing loss. The first is conductive hearing loss. This happens when there is a problem with sound waves getting through the outer or middle ear. Think of it like a blocked pipe. Common causes include a buildup of earwax, fluid in the middle ear, often called glue ear, especially in children, an ear infection, a perforated eardrum, or problems with the tiny bones in the middle ear. The good news is that conductive hearing loss can often be treated with medicine or surgery, and the hearing can be restored. The second type is sensorineural hearing loss. This occurs when there is damage to the inner ear, the cochlea, or the auditory nerve that connects the ear to the brain. This is more like a problem with the electrical wiring. The most common cause is simply aging, a condition known as presbycusis. Another major cause is exposure to loud noise over a long period, which damages the delicate hair cells in the cochlea. Other causes can include certain viral infections, some medications that are toxic to the ear, head injuries, or genetic factors. This type of hearing loss is usually permanent. Diagnosing hearing loss involves a thorough history and an ear examination to look for obvious blockages or infections. The key diagnostic test is an audiogram, performed by an audiologist. This test plays sounds at different pitches and volumes to pinpoint the type and severity of the hearing loss. Management depends on the cause. For conductive loss, removing wax, treating an infection, or surgery might be the answer. For permanent sensorineural hearing loss, the main treatment is hearing aids, which amplify sounds. For profound deafness, cochlear implants, which directly stimulate the auditory nerve, can be an option. A huge part of nursing care is supporting patients as they adapt to their hearing loss and learn to use their hearing aids. Let's walk through another nursing care plan, this time for an older adult experiencing gradual hearing loss. Our patient is Mr. Chen, a 78-year-old retired librarian who lives with his wife. His wife has brought him to the clinic because she is worried about his hearing. He seems withdrawn, and she says the television is always on very loud. As with Mrs. Gable, our process begins with careful assessment, moves to diagnosis, and then on to planning our interventions, always keeping the patient at the center of our care and thinking about the impact on their life. First, we gather our subjective and objective data. Subjective data. Mr. Chen says, "I'm fine. My wife just fusses." But when prompted, he admits, "People do seem to mumble a lot these days, and I miss parts of conversations, especially in noisy places. It's easier just to stay quiet." His wife adds, "He doesn't answer when I call him from another room, and he stopped going to his weekly book club." Objective data. During conversation, we observe that Mr. Chen watches our faces intently. We have to repeat questions for him. An otoscope examination shows his ear canals are clear with no wax buildup. A simple whisper test confirms he has difficulty hearing quieter sounds. From this information, we can form a nursing diagnosis. A very relevant one would be impaired social interaction related to difficulty hearing, as evidenced by the patient's reported withdrawal from social activities and his wife's account of him not joining in conversations. Another could be risk for injury related to inability to hear auditory warnings such as smoke alarms or approaching traffic. This highlights that hearing loss is not just a communication issue, it's also a safety issue that we must address in our care plan. Our goal and interventions will focus on communication, safety, and emotional support. Goal: Mr. Chen will attend a referral appointment with an audiologist within 1 month and will be able to demonstrate 2 effective communication strategies with his wife. Nursing interventions. 1. Speak clearly and slowly, facing Mr. Chen directly. Do not shout, as this can distort sound. 2. Provide written information about the importance of a formal hearing test. 3. Discuss the referral to an audiologist with Mr. Chen and his wife, explaining what to expect. 4. Educate both of them on simple communication tactics, such as reducing background noise and ensuring they have each other's attention before speaking. And 5. Discuss safety adaptations at home, such as visual alerts for the doorbell and smoke alarm. As we've seen, problems affecting the ear, nose, and throat are a huge part of healthcare. From the simple sniffle of rhinitis to the life-threatening emergency of a laryngeal obstruction, these conditions touch the lives of our patients in profound ways. They can interfere with the most basic human functions: breathing, communicating, eating, and connecting with the world around us. Your journey as a nurse will bring you face to face with these challenges every day. Your understanding of the underlying anatomy and the specifics of each condition is the foundation upon which you will build your excellent nursing practice. Your role as a nurse in managing these conditions is multifaceted and absolutely vital. First and foremost, you are the assessor and the early warning system. You are often the first person to see the patient, to listen to their story, and to spot the subtle signs that something is wrong. Your sharp assessment skills can be the difference between catching a problem early and dealing with a crisis later. Whether it's recognizing the stridor of an obstructed airway or noticing the social withdrawal that signals hearing loss, your observation and quick thinking are indispensable to patient safety and well-being. Beyond assessment, you are the provider of hands-on care and the patient's educator. You will be the one administering treatments, whether it's teaching someone how to use a nasal spray for the first time, providing comfort with a warm compress, or helping someone insert their hearing aids. Your ability to explain complex information in a simple, clear, and kind way empowers patients to take control of their own health. When you teach a patient and their family how to manage a chronic condition like allergies or hearing loss, you are giving them a gift of independence and improving their quality of life long after they leave your care. Finally, never underestimate your role as a source of emotional support. Being unable to breathe properly is terrifying. Losing your hearing can be incredibly isolating. Dealing with chronic pain is exhausting. As a nurse, you are there to provide not just physical care, but also comfort, reassurance, and a compassionate ear. You are the calm presence in an emergency, the encouraging voice when a treatment is difficult, and the trusted professional who helps patients and families navigate their fears. In the world of ENT care, your knowledge, your skills, and your compassion are truly at the heart of healing. Your next nursing exam, although this will definitely help. It's about understanding what your patients are going through, being able to spot the signs early, and providing the best possible care. From a simple earache to more complex issues, knowing the what, why, and how is crucial for every healthcare professional. We're going to cover a lot of ground, but don't worry, I'll make it super clear and practical. We'll look at everything from deformities you might see at birth, to that stubborn impacted wax, to the all too common middle ear infection. Think of this as your comprehensive guide, designed to build your confidence whether you're on the ward or in the classroom. Let's break down each disorder with causes, symptoms, and key nursing management tips. Ready? Grab your notes, get comfortable, and let's get started. Our goal today is to demystify these conditions. The ear is an incredibly delicate and complex organ, and when things go wrong, it can cause significant pain and distress for our patients. As nurses, we're on the front lines. We're the ones assessing the pain, educating the families, and administering the treatments. So, having a solid foundation of knowledge is non-negotiable. By the end of this video, you'll be able to differentiate between various ear disorders and understand your critical role in managing them effectively. First up, let's talk about the visible part of the ear, the external ear, and the deformities that can occur. These often present at birth and are known as congenital defects. One of the most significant is microtia, which literally means small ear. In these cases, the external ear, or pinna, is underdeveloped and smaller than normal. The severity can range from a slightly smaller ear to one that's just a small nub of tissue. It's a spectrum, and it's important to recognize the variation. Then you have the most extreme form, which is called anotia. In this condition, the external ear is completely absent. This can be unilateral, affecting one ear, or bilateral, affecting both. Of course, the immediate concern for parents and healthcare providers is hearing. If the ear canal and middle ear structures are also affected, which they often are, it can lead to significant conductive hearing loss. So, a thorough audiological evaluation is one of the very first steps after birth. Another common deformity you'll see is what's often just called a protruding or prominent ear. This happens when the cartilage of the ear doesn't fold correctly during development, causing the ears to stick out more than usual. While this typically doesn't affect hearing at all, it can become a major source of psychological distress for a child, especially as they enter school and become more aware of their appearance. Teasing and bullying are real concerns here. So, what's our role as nurses? It starts with assessment and identification. When you're doing that newborn assessment, you're looking at everything, including the ears. Noting any asymmetry, malformation, or unusual positioning is key. But beyond the physical, our role expands significantly into providing support. For parents of a child with microtia or anotia, the diagnosis can be shocking and overwhelming. They'll have a million questions about hearing, surgery, and their child's future. We need to be that calm, knowledgeable presence. We facilitate connections with specialists like audiologists, ENT surgeons, and plastic surgeons. We provide resources and information in a way they can understand, breaking down complex medical terms. The management often involves a multidisciplinary approach. For hearing loss, bone-anchored hearing aids, or BAHAs, might be an option. For the physical deformity, surgical correction, or otoplasty is often performed. For protruding ears, an otoplasty is a common cosmetic procedure, usually done around age 5 or 6, when the ear cartilage is more stable, but before the child faces significant social pressure. For microtia, reconstructive surgery is a much more complex process, often involving multiple stages, and using the patient's own rib cartilage to create a new ear framework. It's an incredible surgical feat, but it's a long journey for the patient and their family. Throughout this entire process, the nurse's role in providing emotional support is paramount. We're there to listen to the patient's and family's fears, to celebrate the small victories, and to manage post-operative care. This includes wound care, pain management, and educating them on how to protect the newly reconstructed ear. It's a powerful reminder that we don't just treat conditions, we care for people. Now let's move on to one of the most common complaints you'll encounter in any clinical setting, otalgia, or simply ear pain. The first thing to understand about otalgia is that the pain doesn't always originate in the ear itself. We categorize it into primary otalgia, where the cause is actually within the ear, and referred otalgia, where the pain is coming from somewhere else, but is felt in the ear. This is a crucial distinction to make during your assessment. Let's start with primary causes. Otitis externa, also known as swimmer's ear, is a big one. This is an infection of the outer ear canal, often caused by bacteria or fungi thriving in a moist environment. Think of kids who spend all summer in the pool. Another common primary cause is impacted ceramin, or earwax, which we'll discuss in more detail later. A foreign body, a perforated eardrum, or a middle ear infection, otitis media, are all classic primary causes of ear pain. But what about that referred pain? This is where your detective skills as a nurse really come into play. The ear shares nerve pathways with many other structures in the head and neck. So, a problem in one of those areas can send pain signals that the brain interprets as coming from the ear. A classic example is dental issues. An abscessed tooth, particularly a molar, can present as severe ear pain with a completely normal-looking ear exam. Other sources of referred pain can include temporomandibular joint dysfunction, or TMJ, where issues with the jaw joint cause pain that radiates to the ear. Pharyngitis or tonsillitis, a sore throat, can also cause referred ear pain. In more serious, though less common cases, tumors in the throat, larynx, or tongue can present with persistent, unexplained otalgia. This is why a thorough history is so incredibly important. Don't just focus on the ear. Your nursing assessment is the cornerstone of figuring this out. Start with a comprehensive pain assessment, using a standardized scale like the 0 to 10 scale. Ask about the onset, location, duration, characteristics, aggravating factors, and relieving factors. Is the pain sharp, dull, throbbing? Does it hurt more when they chew? Have they been swimming? Do they have a sore throat or toothache? These questions are your clues. Patient education is another huge part of your role. If it's otitis externa, you'll be teaching them how to administer ear drops correctly, having them lie on their side, pulling the pinna up and back for adults, and staying in that position for a few minutes to let the medication work. You'll also educate them on prevention, like using drying drops after swimming and avoiding the use of cotton swabs that can damage the ear canal. If the pain is referred, your education will focus on the primary cause. For a dental issue, you'll be emphasizing the need to see a dentist. For TMJ, you might discuss soft diets, avoiding gum chewing, and stress reduction techniques. The key is to help the patient understand the connection between, say, their jaw clenching and their ear pain. By doing a thorough assessment and providing clear education, you empower the patient and ensure they get the right treatment for the real problem. This is a scenario that plays out in emergency rooms and pediatric clinics everywhere. A child comes in, crying or distressed, and the parent says, "I think they put something in their ear." Foreign bodies in the ear are incredibly common, especially in toddlers and young children, who are naturally curious and exploring their world with their hands and mouths. They put things in their nose, their mouth, and yes, their ears. It's a developmental stage, but one that can lead to some tricky situations. What kind of objects are we talking about? The list is practically endless. You'll see beads, small toy parts like Lego pieces, pebbles, and pieces of crayon. Food items are also very common, things like popcorn kernels, seeds, or beans. In adults, you might see a piece of a cotton swab that broke off, or an insect that crawled or flew into the ear canal. An insect in the ear can be particularly distressing because of the buzzing and movement. The symptoms can vary. Sometimes, the child might not have any symptoms, and the parent only discovered it by chance. More often, there will be pain, a feeling of fullness in the ear, and some degree of hearing loss on the affected side. If the object has been there for a while, you might see a foul-smelling discharge, which indicates a secondary infection is brewing. If it's an insect, the patient will report a loud buzzing or a crawling sensation, which can cause a lot of anxiety. Here's the most important rule for everyone, from parents to healthcare providers. Never attempt a blind removal. You can't see what you're doing, and poking around in the ear canal with tweezers, a paperclip, or anything else is incredibly dangerous. You risk pushing the object deeper, which can wedge it in the bony part of the canal, making it much harder to remove. Even worse, you could perforate the eardrum or damage the delicate bones of the middle ear, causing permanent hearing loss. So what is the nurse's role? First and foremost, keep the patient calm. This is especially true with children. A scared, squirming child makes a delicate procedure nearly impossible and much more dangerous. Use a calm voice, explain things in simple terms, and provide distraction. Sometimes a parent holding the child securely is enough. In other cases, procedural sedation might be necessary, and you'll be responsible for preparing the patient and monitoring them. Your job is to assist the physician or advanced practice provider who will be performing the removal. This means having the right equipment ready. This might include an otoscope for visualization, special instruments like alligator forceps or a cerumen loop, and an irrigation setup. For an insect, the first step is often to kill it by instilling mineral oil or lidocaine into the ear canal to stop the movement and buzzing. Then, it can be flushed or suctioned out. After the object is removed, the ear canal needs to be inspected again to check for any trauma, like cuts or a perforation of the eardrum. Antibiotic ear drops may be prescribed to prevent or treat infection. Your role then shifts back to patient education. You'll teach the family how to administer the drops and advise them on keeping the ear dry. And for parents of young children, you'll provide anticipatory guidance about supervising playtime and keeping small objects out of reach to prevent it from happening again. When we think about ear problems, tumors might not be the first thing that comes to mind, but they are a clinical reality we need to be aware of. Tumors of the external ear can be either benign, meaning non-cancerous, or malignant, meaning cancerous. Recognizing the potential signs and understanding the nurse's role in care is vital. The external ear, especially the helix or top rim, is exposed to the sun, making it a common site for skin cancers. Let's start with benign tumors. These are more common and include things like cysts, keloids, and osteomas. Sebaceous cysts can form from blocked oil glands. Keloids are overgrowths of scar tissue that can form after an injury, like an ear piercing. They can become quite large and cosmetically bothersome. Osteomas are benign bony growths that can occur within the ear canal, sometimes associated with frequent exposure to cold water, a condition known as surfer's ear. While benign tumors are not life-threatening, they can cause problems. An osteoma might grow large enough to block the ear canal, leading to wax impaction and hearing loss. A keloid can be itchy, tender, and cause significant emotional distress due to its appearance. Management for these often involves surgical excision if they are symptomatic or cosmetically concerning. Your role here involves pre-op teaching and post-op wound care. Now for the more serious category, malignant tumors. The vast majority of these are skin cancers. Basal cell carcinoma, or BCC, is the most common. It often appears as a pearly, flesh-colored papule with tiny blood vessels on the surface. Squamous cell carcinoma, or SCC, is the next most common. It might look like a firm, red nodule, or a scaly, crusted, non-healing ulcer. Melanoma, while less common on the ear, is the most dangerous and can appear as an irregularly shaped, dark-colored mole. The biggest red flag for a malignant tumor is a sore or ulcer on the ear that just won't heal. A patient might say they've had a pimple or a sore spot for months, and it occasionally bleeds and scabs over, but never fully goes away. This history should immediately raise your suspicion. Chronic sun exposure is the #1 risk factor, so be sure to ask about their history of sunbathing, outdoor work, and sunscreen use. When a malignant tumor is suspected, a biopsy is necessary to confirm the diagnosis. A small piece of the suspicious tissue is removed and sent to a pathologist for examination. If cancer is confirmed, The treatment is almost always surgical. The goal is to remove the entire tumor with a margin of healthy tissue around it. For larger tumors, this can be quite disfiguring and may require complex reconstruction by a plastic surgeon. The nurse's role in caring for a patient with an external ear tumor is multifaceted. It begins with that initial assessment and recognizing the suspicious lesion. If a biopsy is done, you'll assist with the procedure and provide wound care instructions. If surgery is required, you'll be involved in the entire perioperative process. But crucially, this diagnosis comes with a lot of fear and anxiety. Providing emotional support, answering questions, and connecting patients with resources is just as important as the physical care. You're their advocate and guide through a very stressful time. Let's talk about something that seems simple, but can cause a surprising amount of trouble. Cerumen impaction, or impacted earwax. Cerumen itself isn't a bad thing. In fact, it's a natural protective substance. It's produced by glands in the outer third of the ear canal and has lubricating and antibacterial properties. It helps to trap dust, dirt, and other small particles, preventing them from reaching the eardrum. Your ears are designed to be self-cleaning. The problem arises when this self-cleaning mechanism fails or is interfered with. Normally, the slow migration of skin in the ear canal, combined with jaw movements from talking and chewing, helps to gradually move old earwax from the inside out, where it flakes off or is washed away. However, for some people, this process doesn't work as well. They might naturally produce a lot of wax, or the wax they produce might be drier and harder than normal. This is where we get into the causes of impaction. One of the biggest culprits is improper ear hygiene. I'm talking about the use of cotton swabs, bobby pins, or other objects to clean the ears. When you stick something in your ear, you're not actually cleaning it. You're pushing the majority of the wax deeper into the canal, past the area where it's produced, and into the bony part of the canal where it can't escape. You're literally packing it in. Other causes include having very narrow or unusually shaped ear canals, which can make it harder for wax to migrate out. As we age, our cerumen tends to become harder and drier, increasing the risk of impaction. Also, people who use hearing aids or earplugs regularly can be more prone to impaction because these devices can block the normal outward movement of the wax. You're essentially putting a dam in the river. The symptoms of cerumen impaction can come on gradually or suddenly. The most common complaint is a feeling of fullness or blockage in the ear. This is often accompanied by a partial, conductive hearing loss. The patient might say their hearing suddenly went out after a shower, which happens when water gets trapped behind the wax plug and causes it to swell. Other symptoms can include tinnitus, which is ringing in the ear, dizziness, or even an earache. As a nurse, management starts with assessment and education. When a patient complains of these symptoms, you'll assist the provider in visualizing the ear canal with an otoscope to confirm the diagnosis of impaction. Treatment usually involves softening the wax first with cerumenolytic agents, over-the-counter drops like Debrox, or even just mineral oil. These are instilled in the ear for several days to soften the hard plug. Once the wax is softened, it can be removed. This can be done through gentle irrigation, using a syringe with warm water to flush the wax out. It can also be done manually by a trained provider using a special tool called a cerumen loop or curette, along with suction. The most important patient education you can provide is to stress the importance of proper ear hygiene. Nothing smaller than your elbow in your ear. Advise them to clean the outer ear with a washcloth and to avoid cotton swabs entirely. Imagine a sudden, sharp pain in your ear, maybe a loud pop, followed by relief and then a weird draining sensation. This is the classic presentation of a tympanic membrane perforation, or a ruptured eardrum. The tympanic membrane is the thin, cone-shaped membrane that separates your external ear from your middle ear. It's incredibly important for hearing. It vibrates when sound waves hit it, and those vibrations are then transferred to the tiny bones in the middle ear. So, what can cause this delicate membrane to tear or rupture? There are a few main categories of causes. The first is infection, specifically a middle ear infection, or otitis media. When an infection builds up fluid and pressure in the middle ear space behind the eardrum, that pressure can become so great that it causes the membrane to burst. This is actually the body's way of relieving the pressure, which is why the intense pain often subsides suddenly once the perforation occurs. The second major cause is trauma. This can be direct trauma, like trying to clean your ear with a cotton swab or a bobby pin and accidentally poking too far. It can also be caused by a foreign object being pushed too deep into the ear. A slap to the ear can also cause a perforation by creating a sudden pressure wave. This is also the mechanism behind barotrauma, which is injury due to pressure changes. This can happen during scuba diving, flying in an airplane, or even from a nearby explosion. The symptoms, as I mentioned, often start with a sudden, severe ear pain that may then quickly resolve. The patient might hear a pop. After the rupture, they may experience drainage from the ear, which can be clear, pus-filled, or bloody. They will also likely have some degree of hearing loss, which can feel like the ear is plugged. Tinnitus, or ringing in the ear, and vertigo or dizziness are also possible, especially if the inner ear is affected. When you encounter a patient with a suspected perforation, the number one rule of nursing management is to keep the ear dry. You must instruct the patient not to allow any water to enter the ear canal during bathing or showering. You can advise them to place a cotton ball coated in petroleum jelly in the outer ear to act as a barrier. Getting water into the middle ear through the perforation can lead to a serious infection. Diagnosis is made by visualizing the hole in the eardrum with an otoscope. In many cases, small perforations will heal on their own within a few weeks to months, much like a cut on your skin. The provider might prescribe antibiotic ear drops if there are signs of infection, but sometimes they will just recommend watchful waiting. Pain can be managed with over-the-counter analgesics like acetaminophen or ibuprofen. For larger perforations, or those that don't heal on their own, surgery may be necessary. The procedure is called a tympanoplasty or myringoplasty, where a surgeon uses a graft, often a small piece of tissue from behind the ear, to patch the hole. As a nurse, you'll be involved in preparing the patient for this surgery and providing post-operative care, which again, heavily emphasizes keeping the ear completely dry to allow the graft to heal properly. If you work in pediatrics, you will see otitis media, or a middle ear infection, almost every single day. It is one of the most common childhood illnesses and the number one reason for antibiotic prescriptions in children. It's an inflammation or infection of the middle ear, which is the air-filled space behind the eardrum that contains the tiny vibrating bones of the ear. Understanding why it's so common in kids is key to understanding the condition. The main reason has to do with anatomy. The middle ear is connected to the back of the throat by a small tube called the eustachian tube. Its job is to drain fluid and equalize pressure. In children, this tube is shorter, narrower, and more horizontal than it is in adults. This makes it much easier for bacteria and viruses from a cold or sore throat to travel up the tube into the middle ear. It also means the tube doesn't drain as effectively, allowing fluid to get trapped. So the classic story is that a child has an upper respiratory infection, a runny nose, a cough, a sore throat, and then a few days later, they start developing ear pain. The infection causes the eustachian tube to become swollen and blocked. Fluid gets trapped in the middle ear, and this stagnant fluid becomes a perfect breeding ground for bacteria or viruses to grow, leading to a full-blown infection. The symptoms of acute otitis media are pretty classic. In older children who can talk, they'll complain of a severe, often throbbing earache. They might say their ear feels full. You'll also see systemic signs like fever. In infants and toddlers who can't verbalize their pain, you have to look for behavioral clues. They might be irritable, crying inconsolably, have trouble sleeping or eating, and they will often tug or pull at the affected ear. When you look in the ear with an otoscope, you won't see a normal, pearly gray, translucent eardrum. Instead, you'll see a red, bulging tympanic membrane. You lose the landmarks because of the swelling and the pressure from the pus building up behind it. This is the hallmark sign of acute otitis media. Sometimes, as we discussed, this pressure builds so much that the eardrum perforates, and you'll see pus draining from the ear canal. Management focuses on a few key areas. First is pain and fever control. This is a top nursing priority. Acetaminophen or ibuprofen should be recommended to keep the child comfortable. For many years, the immediate response was to prescribe antibiotics. However, we now know that many ear infections are viral and will resolve on their own. Current guidelines often recommend a watchful waiting approach for 48 to 72 hours in certain children to see if symptoms improve without antibiotics, in an effort to reduce antibiotic resistance. If the infection is severe, persistent, or occurs in a very young infant, antibiotics like amoxicillin are prescribed. Your role is to educate the parents on the importance of completing the entire course of antibiotics, even if the child feels better after a few days. For children who have recurrent otitis media, meaning 3 or 4 infections in 6 months, a referral to an ENT specialist is warranted. They may be a candidate for myringotomy tubes, or ear tubes, which are tiny cylinders placed through the eardrum to help drain fluid and prevent future infections. And that's a wrap on our deep dive into the most common external and middle ear disorders. We've covered a lot, from congenital deformities and traumatic injuries to those pesky infections and wax blockages. The big takeaway here is that as nurses, our role goes way beyond just following orders. It's about sharp assessment skills, understanding the why behind the symptoms, and providing compassionate, patient-centered education. Remember, early identification and proper nursing care can prevent complications in ear disorders, preserving hearing and improving quality of life for our patients. I hope breaking down the causes, symptoms, and nursing management tips for each of these conditions has given you a more solid and confident understanding. Whether you're studying for an exam or you're on the floor dealing with a crying child with an earache, this knowledge is your power. It allows you to anticipate patient needs, calm fears, and be a truly effective member of the healthcare team. Keep asking questions, stay curious, and always advocate for your patients. Thanks so much for sticking with me through all of that. I know it was a ton of information, but it's all incredibly important. If you found this video helpful, make sure to hit that like button, subscribe if you haven't already, and share it with a classmate or colleague who might benefit. In the next part, we'll cover inner ear disorders and their management, so stay tuned. We'll be talking about things like vertigo, Meniere's disease, and hearing loss. As always, stay healthy, and I'll see you in the next video. Hello, future nurses. Welcome to the fascinating world of the ear, nose, and throat, or ENT as we often call it. You might be wondering why this area is so important in your nursing journey. Well, think about how much we rely on our senses every single day. We listen to music, chat with friends, smell our favorite foods, and taste delicious meals. Our ability to hear, smell, and even maintain our balance is all thanks to the intricate and connected systems within our ENT region. These abilities are fundamental to our quality of life, allowing us to interact with the world, communicate effectively, and stay safe from harm. As a nurse, you will encounter patients whose lives are significantly impacted when these systems go wrong. Understanding ENT disorders is not just for specialists, it's a core part of providing holistic care. Imagine a patient who can't hear their doctor's instructions, an older person at constant risk of falling due to dizziness, or someone who has lost their sense of taste and smell, leading to poor nutrition and depression. These are real-life scenarios you will face on the wards. Your knowledge will be the bridge that helps these patients navigate their challenges. By grasping the basics of ENT health, you can make a profound difference, helping people to communicate, stay safe, and enjoy life's simple pleasures once more. It's an area where your keen observation and compassionate care can truly shine. Your role will extend far beyond just administering medication. You'll be a detective, picking up on subtle clues during your assessments that might point to an underlying ENT issue. You will be an educator, explaining complex conditions in simple terms that patients and their families can understand. You will also be a source of comfort and support, helping individuals cope with the anxiety and frustration that often accompany these disorders. For example, sudden hearing loss or persistent vertigo can be incredibly frightening. Your calm, informed presence can be a lifeline for someone feeling overwhelmed and isolated. This is why a solid foundation in ENT is not just helpful, it's essential for every single nurse. So, as we dive into this topic, I want you to think of yourselves as guardians of your patient's connection to the world. We're going to explore the amazing anatomy of the ear, nose, and throat, and then focus on some common inner ear disorders you're likely to see. We'll cover how to spot them, what they mean for your patient, and the practical steps you can take to provide the best possible care. This isn't just about passing your exams. It's about building the confidence and competence to support your patients when they need you most. Let's get started on this exciting and vital part of your nursing education. Let's start our tour with the ear, an incredible organ with a dual-purpose hearing and balance. It's cleverly divided into three main parts. First up is the external ear, which is the part you can see, the pinna, and the ear canal. Its job is like a satellite dish, collecting sound waves from the environment and funneling them inwards towards the eardrum. Think of it as the entrance hall, gathering all the information before it's processed deeper inside. The ear canal also has tiny hairs and produces wax to help protect the more delicate parts of the ear from dust and other foreign objects, acting as a natural security guard for this important structure. Next, we move into the middle ear, a small air-filled space just behind the eardrum. Here you'll find three of the tiniest bones in the human body: the malleus, or hammer, incus, which is the anvil, and stapes, also known as the stirrup. When sound waves make the eardrum vibrate, these little bones act like a team of drummers, passing the vibrations along and amplifying them. The middle ear is also connected to the back of your throat by a tiny tube called the eustachian tube. This tube helps to equalize the pressure on both sides of your eardrum, which is why your ears might pop when you're on a plane or going up a hill. Now for the main event, the inner ear. This is the most complex and delicate part, hidden deep within the bone of your skull. It contains two key structures. The first is the cochlea, a snail-shaped tube filled with fluid and lined with thousands of tiny hair cells. When the vibrations from the middle ear reach the cochlea, they cause the fluid to move, which in turn stimulates these hair cells. These cells then convert the movement into electrical signals, which are sent to the brain via the auditory nerve. Your brain then interprets these signals as the sounds you recognize, from a whisper to a loud concert. The second part of the inner ear is the vestibular system, which is our body's personal balance center. It's made up of three semicircular canals and two other structures called the utricle and saccule. These are also filled with fluid and have sensory hair cells. Whenever you move your head, whether you're nodding, shaking it, or tilting it, the fluid inside these canals moves and stimulates the hair cells. They send messages to your brain about your head's position and movement. Your brain then uses this information, along with signals from your eyes and muscles, to help you keep your balance and stay upright. It's a remarkable system that works silently in the background every second of the day. Let's talk about a condition that can feel like a personal storm inside your head. Meniere's disease. This is a disorder of the inner ear that causes sudden, unpredictable attacks of severe dizziness or vertigo. Imagine feeling like the room is spinning violently without any warning. These attacks can be accompanied by a range of other symptoms, including a roaring or ringing sound in the affected ear, which we call tinnitus, a feeling of fullness or pressure in the ear, and fluctuating hearing loss. the hearing loss can become permanent over time. These episodes can last anywhere from 20 minutes to several hours, leaving the person feeling exhausted and unwell afterwards. The exact cause of Meniere's disease isn't fully understood, but it's thought to be related to a buildup of fluid, called endolymph, in the inner ear. Think of it like a plumbing problem where there's too much fluid in the system, creating excess pressure that disrupts the delicate balance and hearing mechanisms within the cochlea and vestibular system. This pressure change is what triggers the sudden and severe symptoms. While we don't know why this fluid buildup happens, potential triggers for an attack can include media group, nurse counseling patient about stress and diet in office, patient filling out medical questionnaire with triggers listed, stock widely distribute equally, stress, fatigue, dietary factors like high salt intake, and even changes in atmospheric pressure. It typically affects adults, usually between the ages of 40 and 60. As a nurse, your management of a patient with Meniere's disease focuses heavily on safety and symptom relief during an attack. When a patient experiences vertigo, your immediate priority is to prevent falls. Help them to lie down in a comfortable position, often in a quiet, darkened room, and advise them to keep their head as still as possible. They might feel very nauseous, so have a sick bowl ready and offer anti-sickness medications as prescribed. Reassuring the patient is crucial, as these attacks can be incredibly frightening. Using a calm voice and explaining what is happening can help reduce their anxiety. For long-term management, patient education is key. You'll teach patients about lifestyle modifications that can help reduce the frequency and severity of attacks. This often includes media group, nurse discussing diet and lifestyle changes with patient, nurse pointing to low-salt foods on tablet, patient practicing relaxation techniques in clinica stock distribute subsequently, advising a low-salt diet as salt can cause the body to retain fluid, potentially worsening the buildup in the inner ear, encouraging them to manage stress through relaxation techniques, ensuring they get enough rest, and advising them to avoid caffeine and alcohol. It's about empowering the patient to take control of their condition and identify their personal triggers, helping them navigate life with more confidence and less fear of the next storm. Another common inner ear issue you'll encounter is labyrinthitis. The name gives you a clue. Itis means inflammation, and labyrinth refers to the delicate, maze-like structures of the inner ear, the vestibular system and cochlea. So, labyrinthitis is the inflammation of the inner ear. This is most often caused by a viral infection, such as a cold or flu, but it can occasionally be due to a bacterial infection. When this area becomes inflamed, it can't send the correct signals to the brain about balance and head position. This results in a sudden and severe onset of vertigo, dizziness, nausea, and vomiting. Unlike Meniere's, the vertigo in labyrinthitis can be constant for several days before it starts to slowly improve. The symptoms of labyrinthitis can be very disabling in the short term. Patients often feel so dizzy that they are unable to stand or walk, and any head movement makes the spinning sensation much worse. They may also experience some hearing loss and tinnitus in the affected ear. Your nursing care is centered on providing support and managing these intense symptoms. Just like with a Meniere's attack, safety is paramount. Keep the bed rails up and ensure the patient doesn't try to get up without assistance. Administering prescribed medications to control the nausea and dizziness is essential. And again, a quiet, dimly lit environment can help reduce sensory overload and make the patient feel more comfortable while they recover. Now let's switch gears to ototoxicity. This is a term that means ear poisoning. It refers to damage to the inner ear, specifically the cochlea or the vestibular system, caused by a medicine or chemical. Unfortunately, some very useful and life-saving drugs can have this harmful side effect. The most well-known culprits include certain powerful antibiotics, like gentamicin, some chemotherapy drugs used to treat cancer, and even high doses of aspirin. The damage can affect hearing, balance, or both, and in some cases, it can be permanent. This is why careful monitoring is so important, when patients are receiving these medications. Your role as a nurse in preventing and managing ototoxicity is absolutely vital. It starts with being aware of which medications carry this risk. When administering these drugs, you must follow protocols for safe dosage and administration rates precisely. Your most important job is to be a vigilant monitor. You need to assess your patient for early signs of ototoxicity, which can be subtle. Ask them if they've noticed any new ringing in their ears, tinnitus, any changes in their hearing, or any feelings of unsteadiness or dizziness. If a patient reports any of these symptoms, you must report it to the medical team immediately. Early detection can allow the doctors to stop or change the medication, potentially preventing irreversible damage. A thorough assessment is your best tool for uncovering ENT problems. It all starts with a good conversation, which we call taking a patient history. When a patient comes in with an ear, nose, or throat complaint, you need to be a detective and ask the right questions. Start with their main complaint. Use the PQRST method, provocation or palliation. What makes it better or worse? Quality or quantity? What does it feel like, and how bad is it? Region or radiation? Where is it, and does it spread? Severity. On a scale of 0 to 10, how bad is it? And timing. When did it start? And is it constant, or does it come and go? These questions help you build a clear picture of the problem. Next, you need to dig a little deeper into their history. Ask about any associated symptoms. For an ear problem, are they also experiencing dizziness, ringing in the ears, tinnitus, hearing loss, or any discharge? For a nose issue, is there congestion, a runny nose, sneezing, or facial pain? You should also ask about their past medical history. Have they had similar problems before? Do they have a history of allergies, frequent infections, or any previous surgeries on their ears, nose, or throat? It's also really important to ask about their medications, including over-the-counter drugs and supplements, as some can cause ENT symptoms. Remember ototoxicity. After gathering the history, you'll move on to the physical assessment. You don't need fancy equipment to start. Begin by simply looking. Inspect the external ears for any redness, swelling, or deformities. Look at the nose for any swelling, asymmetry, or discharge. Ask the patient to open their mouth and use a pen torch to look at their throat, checking the tonsils and the back of the pharynx for redness or swelling. You can gently press on the sinuses, above the eyebrows and on the cheeks, to check for any tenderness, which might suggest a sinus infection. These simple observational skills are incredibly powerful. For a more detailed ear examination, you will learn to use an otoscope. This is a handheld tool with a light and a magnifying lens that allows you to look inside the ear canal and at the eardrum. You'll be looking for things like excess wax, foreign objects, redness or swelling in the canal, and signs of infection. A healthy eardrum should look pearly gray and slightly shiny. You will also perform some simple hearing tests, like the whisper test, where you stand behind the patient and whisper a series of words, asking them to repeat them. For balance, you can observe their gait as they walk or perform the Romberg test, where the patient stands with their feet together and closes their eyes to check for swaying. While your history and physical assessment provide a wealth of information, sometimes we need to take a closer look to confirm a diagnosis. There are several common diagnostic tests used in ENT that you should be familiar with. One of the most fundamental is audiometry. This is a formal hearing test conducted by an audiologist in a soundproof booth. The patient wears headphones and is asked to respond when they hear sounds of different pitches and volumes. The results are plotted on a graph called an audiogram, which shows the exact type and degree of hearing loss. This is essential for diagnosing conditions like Meniere's disease and ototoxicity. Another important set of tests is used to evaluate the balance system. These are broadly known as vestibular function tests. One common test is called video nystagmography, or VNG, and electronystagmography, or ENG. This test measures involuntary eye movements, nystagmus, while the patient performs various tasks, such as following a light with their eyes. The test also involves putting warm and cool water or air into the ear canal, which stimulates the inner ear balance system and should normally cause a specific type of eye movement. Abnormal results can help pinpoint whether the balance problem is coming from the inner ear, helping to diagnose conditions like labyrinthitis. Sometimes, we need to see the structures of the ear, nose, and throat in more detail. This is where imaging tests come in. A computed tomography scan, or CT scan, is excellent for looking at the bony structures of the ear and the sinuses. It can reveal problems like chronic sinus infections, bone erosion from an infection, or structural abnormalities. A magnetic resonance imaging scan, or MRI on the other hand, is much better at showing soft tissues. An MRI might be ordered if the doctor suspects a tumor on the auditory nerve, an acoustic neuroma, or wants to look at the brain to rule out other causes of dizziness, such as a stroke or multiple sclerosis. Finally, for throat and nose issues, a procedure called endoscopy is often used. An ENT specialist will use a thin, flexible tube with a camera and a light on the end, an endoscope, to look directly at the internal structures. For the nose and sinuses, this is called nasal endoscopy. For the throat and voice box, it's called laryngoscopy. This allows the doctor to see any inflammation, polyps, or other abnormalities up close. As a nurse, your role is to prepare the patient for these tests, explain what will happen to reduce their anxiety, and monitor them for any complications after the procedure is complete. So we've journeyed through the complexities of the inner ear and its disorders. Now let's bring it all together and focus on the most important part, your role as a nurse. Your contribution to ENT care is massive, and it rests on several key pillars. The first is assessment and early identification. You are often the first healthcare professional to notice that something is wrong. By conducting a thorough history and physical assessment, and by actively listening to your patient's concerns, you can spot the early warning signs of a condition like ototoxicity or Meniere's disease. Your sharp observational skills can trigger timely intervention, which can make all the difference in a patient's outcome. The second pillar is providing direct care and ensuring patient safety. For a patient in the throes of a vertigo attack from labyrinthitis or Meniere's, your immediate actions are critical. You are the one who will help them to a safe position, administer medications to relieve their distressing symptoms, and create a calm environment that promotes recovery. You are the guardian who implements fall precautions, ensuring the patient's room is free of hazards and that they have a call bell within easy reach. This hands-on practical care provides immediate comfort and prevents further harm, forming the very foundation of patient well-being during an acute episode. The third, and perhaps one of the most empowering, pillars is patient education. Many ENT conditions are chronic, meaning patients have to learn to live with them. This is where you step in as a teacher and a coach. You will be the one explaining dietary changes for Meniere's disease in simple, practical terms. You will teach patients and their families about the signs of ototoxicity to watch for at home. You will demonstrate how to perform balance exercises, vestibular rehabilitation, to help the brain adapt after a bout of labyrinthitis. By giving patients the knowledge and tools they need, you empower them to become active participants in their own care, improving their long-term quality of life. Finally, never underestimate the power of emotional support. Living with a chronic ENT disorder can be isolating and frightening. The unpredictability of Meniere's attacks can lead to anxiety and social withdrawal. The constant ringing of tinnitus can be maddening. Hearing loss can make people feel cut off from their loved ones. As a nurse, you are a source of compassion and empathy. Taking the time to listen, to validate their feelings, and to offer reassurance can have a profound impact on a patient's mental health. You are their advocate, their confidant, and their steady support system. This holistic approach, blending clinical skill with genuine human connection, is truly the heart of nursing in ENT care and beyond.